trial? What went wrong? Is there any new hope for high PEEP trials?
As you know, this trial was performed in the last year. We participated in with some patients and also a little bit in the discussions of the protocol design. And then I think the results of this trial were very surprising, including to us. So this is the protocol and the study published in JAMA. It included many patients across South America, Europe, and also Indonesia. And then the design of the trial was to test two things, the recruitment maneuver and the application of a high PEEP based on respiratory system compliance after the application of the recruiting maneuver. It resulted in a PEEP level in average around 16 centimeters of water, and the control group should be the low PEEP FiO2 table of the ArtsNet, but in fact, because of the bias of some investigators, it went a little bit above this. There was a big improvement in oxygenation, as should be expected, so it means that we got some oxygenation effect. And I call attention to this because some people say that this was a kind of predictable catastrophe. But in fact, if you look at the incidence of pneumothorax, which is 3.2, and was a little bit above the incidence in the control group, it's well below any previous PEEP trial. So keep this in mind. But anyway, something that we cannot deny is that we had a higher incidence of pneumothorax. And then finally, the bad effect in mortality, which was very significant after it's not very, because in fact this significance was marginal, according to the statistical plan, is 0.048. And, certainly it's a trend completely in opposite direction that we were expecting. So because we have been saying that this trial was the result of a sequence of studies, we did lots of physiological studies, we did safety studies, we did phase 1, phase 2, Bob Kaczmarek did perform one study that could be considered as like a phase 2 of this study. This was a kind of backfire for us. So I think I would like to discuss 5 mistakes that we can now understand in retrospect. First of them is effect size versus sample size. This is the difference in driving pressure that we achieved between both arms. We were expecting a much larger difference based on pilot studies. So this difference was just 1.5 centimeter of water. And then we were expecting something like 4 centimeters of water. And based on these mediation analysis of driving pressure, we in the middle of the trial, we were already very, let's say, without any hope that this trial could be positive. What was surprising is that it was negative. So this is the result of some pilot studies when we do individual PEEP titration in patients with ARDS. So typically we get a reduction in driving pressure of 4 centimeters of water. You may say that this is not enough or this is small, but in fact this is exactly almost, let's say, almost half, a little bit more than half of the reduction in driving pressure that you get in the famous ArtsNet study of the year 2000, when you reduce tidal volume from 12 to 6 mL per kilogram. So this is a meaningful result if we had this in average for our patients. But this was not the case. Some other studies showing that it's possible by individually titrating PEEP. In this case, we use electrical impedance tomography to reduce by 6 centimeters of water. And I call attention to this study also performed in our center, and which was published exactly in the last year, in which a recruitment maneuver as aggressive as this one, slightly less but not that much, and then we had a very positive result in terms of outcome, with hard outcomes very different between the patients, between the two arms. Which is the difference here is that I think this population of patient was much more recruitable, and we could document this using electrical impedance tomography in some patients. After the result of this study, we came back to the lab and checking, is it possible that we missed something, and then we were kind of covering the reality in some way, and then we didn't realize the harm associated with these maneuvers. So we did lots of studies in which animals were randomized to receive different levels of driving pressure, the same tidal volume, but just manipulating the PEEP. Setting the PEEP, we could have this big difference in driving pressure. And when we do this, after the promotion of lung injury, so we have a healthy animal, we promote injury, and then we randomize either to a low PEEP FiO2 table or to this open lung approach. The results are remarkable. So why in patients it was so different? We got a reduction in the production of pro-collagen type 1, type 3, and we had some PET studies showing that we had reduced overall lung inflammation. So what happened? I believe that this is the problem of doing a big trial. I was expecting some degradation of the signal, but not as much. So I believe that one of the problems of the trial, I'm skipping this for the sake of time, is that the protocol design was not very good in individualizing patients. Why I'm saying this? This is some histograms of the high PEEP arm, low PEEP arm. This is the change in driving pressure just 1 hour before randomization to after randomization. Just 1 hour change. So the lung should be the same. Any change in driving pressure is because you recruited or you overdistended the lung. And then, as you can see, this is the control group, this is the high PEEP group. In the low PEEP group, half and half. So half of the patients, they increase driving pressure, half of the patient, they decrease driving pressure. This is more or less what I was expecting, because there was no special strategy for PEEP except for correcting FiO2. But in the high PEEP arm, because we are titrating PEEP based on compliance, I had to expect that no patient had an increase in driving pressure. And look what happened. More than 1/3 of the patients, they had an increase in driving pressure. So what is this? Can only be two things. A mistake at the bedside or a bad protocol design, then this is our fault. And interesting enough, if you look at here, the mortality of patients, this is the neutral mortality of the average population. Low PEEP arm and the recruitment arm. So when driving pressure dropped in both groups, the patient, it's a good signal for patients. When driving pressure stays the same, so there is no big deal with the control group, but in the high PEEP, it starts to cause some problems, maybe because of hemodynamics, and you don't get any benefit and you are impairing a little bit of hemodynamics. But when driving pressure increases after randomization, something that could not happen by the philosophy of the protocol, then the patients, they really have a high mortality, very likely because you are causing overdistension and also some hemodynamic problems. So I think this is what caused some of the reasons why this trial was very negative and in fact harmful. The pragmatic design of the trial contributed to this. This is a typical patient of the protocol, PF ratio of 93. We titrated PEEP. In this patient, EIT was there just to monitor, but not to give you a decision. And then, as you can see, when we titrated PEEP from 23 down here to 8 or 7 centimeters of water, there was no collapse. But this patient, by protocol design, because they simplified the sequence of steps, he was placed at this PEEP level with a little bit of overdistension. And certainly in this patient, it was one of the patients in which driving pressure increased. So if you are really titrating individually, you should accept PEEP levels as low as 7 or 5 centimeters of water if this is what the mechanics is telling you. But by protocol design, the minimum PEEP level here was 13. And finally, I think this was the worst mistake, the use of volume control ventilation during the assisted phase of disease. Look at the survival curve. If you take a zoom of the survival curve, the recruitment maneuver was only applied here, and you don't see any signal of harm. On the contrary, in the first 2 days. And then the difference starts to happen exactly 2 or 3 days after you are removing paralysis of the patients. And we documented in many patients that it was very often to have breath stacking. This is one patient of the protocol. Look at this. This is the protective tidal volume of 6 mL per kilogram. This is the signal coming from EIT. And look what was happening with this patient. You know, he was having triple stacking in some breaths and receiving 15 mL per kilogram. So the ventilator was working like a gun machine. And then this patient was far away from a protective ventilation. But you could say, oh, this happened in both arms. Yes, it's true, but this patient was already at a PEEP of 20, very likely very close to TLC. So then you have 15 mL per kilogram on top of 20 of PEEP. No wonder that this patient was reaching plateau pressures around 60. I call attention that breath stacking is not something that is not that uncommon. Bob Kazmarek was talking about this today, and I call attention to you that the ventilator does not give you any warning signal. You can see here the tidal volume is 222, and I have 2 couples of breath stacking, and the ventilator doesn't tell me. So you need a physician at the bedside looking at the waveforms. If we knew this, we hadn't proposed this volume control ventilation. I think it was a double mistake. One mistake is that we didn't know, we couldn't imagine that physicians were going to miss this as much as they did. And the second mistake is that nowadays we know that volume control does not help us to control transpulmonary pressure because of the pendiluft. And then also some studies are telling us that the more you try to reduce the tidal volume, the more you're going to have breath stacking. And we are very ambitious and trying to use 5 mL per kilogram, so the situation got worse. In this trial, the set tidal volume was well below the set tidal volume in previous protective trials. So what's left for the future? Some people are telling me that, okay, the chances of high PEEP are gone. I believe that I'm not done yet. I think certainly high PEEP, over. But individual PEEP, we still have some ideas on how we can get a better trial. First of all, breath stacking should be out. We have to find a solution for this. We need automation, monitoring at the bedside. It's impossible to have any positive trial with the presence of breath stacking, and we have documented that is very often the patients are getting 15 mL per kilogram of tidal volume. But the most important thing is that we should learn a little bit about other areas of research, and we should try to do some predictive enrichment in our protocols. And then in the same way that we can see that some animals, they were already, let's say, recruited, that they don't benefit too much of a high PEEP strategy. Some other animals can benefit a lot. And then, instead of choosing patients based on oxygenation, we should choose patients, select patients based on recruitability. So this is something that we are going to test in the future. We have some tools at the bedside to detect recruitability. Just to give you an idea, this is CT recruitment defined as Gattinoni, and this is the index that you can get from EIT at the bedside, so we can select those patients. And then we should just select those patients for including in the trial and not based on the Berlin criteria. So this is what I had to say. Thank you very much.